Thank you all for being here. I'm Dr. John Howington. I'm the 87th president of the American College of Chest Physicians. And as the president, I get to submit a session to the program committee. And I'm thrilled that my colleagues have agreed to present the AATS chest and STS lung cancer guidelines, and we'll see how they kind of cover the depth and breadth of what we do day to day. And so Dr. Sam Kim from Northwestern University, if you'll please come up and join us and kick us off. Thank you.
Good morning. Thank you for joining this session. The topic I'm going to talk about today is going to be multidisciplinary management and the resectability of locally advanced lung cancer, which will encompass the STS consensus statement that was adopted and published earlier this year in the Annals of Thoracic Surgery. My name is Sam Kim. I'm a thoracic surgeon from Northwestern. I was the lead author on the consensus project. I would like to thank the CHEST for allowing me to present on behalf of my co-authors and STS. This is my closure. The objective of this talk will be to propose the optimal management of locally advanced lung cancer in the light of the latest development in the medical and surgical treatment, and to redefine the term resectability to include not only the technical ability to achieve R0 resection, but also many biological factors that are relevant to the prognosis, including the risk of the operation, effectiveness of the alternative treatment that do not include surgery. In other words, the appropriateness of surgical therapy as a part of an overall patient treatment. So surgery continues to be the mainstay of treatment both for early and selected group of advanced lung cancer. However, its role is rapidly changing as the landscape of the treatment of lung cancer is changing due to rapidly advancement in medical therapy. Thus, agreeing on the resectability takes on a whole new meaning, and the role of a multidisciplinary tumor board takes on the utmost importance in the guidance of the treatment of locally advanced lung cancer. So to help the clinicians and public, the STA has developed a consensus statement to help define what is a resectability and then management of a locally advanced lung cancer in light of the contemporary data. So task force was created, involved 6 thoracic surgeons across the country, along with 2 medical oncologists and 2 radiation oncologists who are the experts in the treatment of lung cancer. And then 3 major themes was developed. First one was assessing the resectability and multidisciplinary management of locally advanced lung cancer. Second theme was the neoadjuvant treatment, and third was the adjuvant treatment. Literature search was performed and formulated a statement, and it required the modified Delphi process of achieving over 80% consensus with 100% participation. And then these statements were then sent for public comments and then approval through the STS workforce. So a total of 19 statements were adopted through this process, ranging from the role of a multidisciplinary tumor board, management of lung cancer, ranging from locally advanced tumor, N1, those that involve N1, single to multi-station N2, T4, and pancreas tumor, neoadjuvant versus a perioperative neoadjuvant treatment, contraindication to induction immunotherapy, and then the role of adjuvant immunotherapy, and then port. So in terms of the interest of time, I'm going to go over some of the highlights of the consensus statements with a brief synopsis. As for the multidisciplinary tumor board, with the stakeholders at the present, our recommendation is that all the locally advanced lung cancer should be presented to discuss the appropriateness of resection and potential induction and ultimate treatment options. There's going to be a higher lung cancer treatment guidelines adherence for those patients who are presented at the multidisciplinary tumor board, with over 90% adherence to the standard of care and guidance algorithm, while the non-accordant patients, those who are not present at the multidisciplinary tumor board, non-accordance were pretty high. Moreover, the resectability should be, we believe that it should be determined upfront with the intention to treat, meaning that neoadjuvant treatment should not be used to convert unresectable tumor into a resectable one. I know that there's some ongoing trial right now looking at whether for the borderline resectable patient, giving an upfront chemoimmunotherapy and then determine resectability. There are ongoing trials like that, but until we have more data, we recommend that resectability should be decided upfront. For medically operative patients, we believe that locally advanced lung cancer without driver mutation, we recommend the neoadjuvant platinum-based chemotherapy with immunotherapy before surgical resection. This recommendation stems from the fact that traditionally systemic treatment, chemotherapy, has been shown to improve overall survival in the tumor greater than 4 centimeter. The recommendation for systemic treatment is even more compelling based on the sort of impressive data we have for adding on an immunotherapy to traditional chemotherapy regimen. This is the data from the Checkmate 816, and then some of the recently published meta-analysis demonstrated that event-free survival, overall survival, and pathological response, complete response improve with the immunotherapy. Now, how about this role between induction, chemoimmunotherapy versus adjuvant treatment in these locally advanced lung cancer? Currently, right now, there's no study that directly compared neoadjuvant to adjuvant chemoimmunotherapy in this setting. For rationale for our recommendation for a neoadjuvant approach is that this adjuvant trial, the adherence to the treatment was only about 65 to 52%. And then these patients need treatment up to a year. Whereas in neoadjuvant treatment trials, when you see the trial, it's a much shorter duration of treatment, and adherence was up to 94 to 100% on these trials. And there's also a theoretical benefit related to antigen priming effect of receiving immunotherapy while the tumor is in situ. How about those patients with the N2 disease with no driver mutation? I don't think there's a whole lot of debate right now in a medically operative patient with a single station N2 disease, non-bulky, recommendation of a neoadjuvant chemo with immunotherapy followed by surgical resection is going to be debated a whole lot. Same thing with a multi-station bulky N2 disease. I don't think a whole lot of surgeons or medical oncologists will offer surgical resection. The debate or gray area tend to be more of a single-station bulky N2 tumor or multi-station non-bulky N2 diseases. For there's no clear data to suggest that surgical resection is superior to other treatment options. But we do believe that for selective cases, particularly if the lobectomy is in the consideration and highly likely, especially let's say PDL score is pretty high, I think recommended surgical resection as a part of the multimodality therapy is a reasonable option. For example, the Nadim trial, the PD-L1 score greater than 25% was very highly predictive of major pathological response. So in these kind of circumstances, extrapolating those data, offering a surgical resection in these kind of patients may be a reasonable option. But I do think that having a frank discussion in the multidisciplinary setting is appropriate. How about those patients with a persistent N2 disease after induction therapy without progression? Obviously, in these kind of patients, we would recommend proceeding with a surgical resection. And I would say we probably don't need to restage this patient routinely, as long as the clinical imaging does not show any disease progression. As majority, if not all, the phase 3 randomized clinical trial did not require mandated any invasive mediastinal restaging in these patient settings. How about the T4 tumors? Including T4 and then pancreas tumor, which represents a heterogeneous group of patients. So in these kind of patients, we do recommend surgical resection in the after induction therapy in the following setting. Now, obviously, these patients should be presented at the multidisciplinary tumor board. Those patients with the N0 or N1 disease, so no N2 disease process, as these patients tend to have a very poor prognosis. And it should be done in an experienced center. If your surgical outcome shows that you have a 4 to 10% mortality, morbidity, I don't think you should really try to undertake this kind of operation that may require coronal resections, very big reconstruction, including vertebral body resection and so forth. So these should be really taken at the center that has experience. And then the pancreas tumor with obviously N2 involvement, we would not recommend surgical resection. But let's say it's the N0, N1, I recommend pre-op concurrent chemoradiation opposed to immunotherapy, as we don't have a whole lot of data on that patient population. How about the neoadjuvant? So currently right now, comparison between neoadjuvant versus perioperative chemoimmunotherapy, there's really no good data to compare one against the another because there's no comparison data. However, I know that there's probably ongoing study now that may look into this, so that gives us more idea. For now, I think either neoadjuvant or perioperative therapy in these approaches are reasonable options, especially stage 2 and higher up. And then in terms of PD-L1 expression in guidance of preoperative therapy, I think PD-L1 expression predicts a response after neoadjuvant therapy. However, those people who lack the PD-L1 expression should not be excluded from consideration for neoadjuvant therapy, because there has been shown that even those people with a very low score still benefit from immunotherapy. How about the contraindication for induction chemoimmunotherapy? For those patients with driver mutation such as EGFR, ALK, ROS1, RET, HER2, and NTRK, additional neoadjuvant therapy to chemotherapy has minimal to no additional efficacy while increasing the potential toxicity such as pneumonitis and the liver dysfunction. Therefore, these patients, we believe that should be treated with induction chemotherapy or chemo-RT, followed by surgical resection and adjuvant targeted therapy. Alternatively, you can even consider surgical resection followed by adjuvant treatment plus or minus chemotherapy in certain algorithms. How about the role of induction targeted therapy? I know that there's currently right now an ongoing trial, including NeoAdjura trial, which I think the data final analysis will come back in 2026, along with a phase 2 Alineo trial. They're looking at the alectinib. We don't have sufficient data to suggest whether this is our recommendation or not. But in the clinical trial setting, I think that this is something that you should explore, but only in that context for now. Finally, offering an adjuvant immunotherapy after surgical resection for locally advanced lung cancer. I think it's a reasonable option based on the reported perioperative immunotherapy trial, especially in the patient with the persistent disease after induction treatment. Although data is less clear on those people with a complete pathological response. So in the exploratory analysis on the Keynote 671, does show that those patients who got the pembrolizumab, regardless whether they had a major pathological response or complete response, all showed an improved benefit in terms of event-free survival. How about the radiation treatment? So for our recommendations are for those with the persistent N2 disease. I don't think it should be used routinely because I do think that there's PORC trial that shows that there's no survival benefit for those patients who underwent the post-op radiation for these patients, although local control or recurrence-free and the media sign was lower. So until more data is accumulated, we don't recommend a routine radiation for persistent N2 disease. However, some patients, I would say, if you have an extensive mediastinal nodal disease, you could consider after discussing with the multidisciplinary tumor board, and then we do recommend for R1 and R2 resection. So this is sort of the summary of the what I've just discussed. So when you take a look at it, for those disease with no nodal involvement N1 and single station N2 disease, I think it's reasonable for us to make a recommendation for surgical resection after induction treatment. However, when it gets to multi-station or bulky single-station tumor, data is still murky, but I think after the context of a discussion at the multidisciplinary tumor board and then maybe the molecular profile, I think it's reasonable to explore that option. For bulky multi-station, I don't think there's any role for surgical resection at this time. Those tumor with advanced tumor like a T4 disease, in general for N0, N1, I think it's reasonable to explore the options of surgical resection. But when it becomes a bulky tumor or multi-station bulky tumor especially, I wouldn't recommend surgical resection. And there's one subset where T4 with a satellite lesion with a single N2 disease, I think there is some data to suggest that those are special subsets. So I think you could consider surgical resection in a selected group of patients. I'd like to thank once again the CHEST for allowing me to give this presentation. These are my co-authors who were extraordinary in terms of developing this consensus statement. Thank you very much.
All right. Let me thank, before I start here, Dr. Howington and the board for this invitation and this honor. So I'm here to talk about the specific recent CHEST guidelines, and this was really for early stage lung cancer. But it's a really boring topic, so I thought I would take you through my thoughts on guidelines as a whole before we get to the specifics. So guidelines, and we're all here to listen to this, they're really not the rule of law. Okay, I think that's a mistake. I think they are rather the suggestions of the rule of medicine. So they are our opinions, our consensus, our distillation, our thoughts about what we think we should be doing. So there is a fair bit of bias that goes into this, but it is somewhat mitigated by the amount of data that is being utilized in order to make said pronouncements. And I really think that these guidelines are really, unfortunately, the basis of medical legal ramifications if there's a gross deviation from these guardrails. And I think that's where we sit. And because of that, the architects, you can't be too restrictive in your covenants. So we have to be fairly neutral, although data-driven, when we make these guidelines, because it is the distillation of all this information that we provide to the end users or the practitioners, which ultimately they have to put their judgment into to determine if these things are in fact practical for their practice. Now, just to give you some examples of guidelines that you think are fairly straightforward, we can just start with peripheral nodules. Now, we could ground glass, but let's just take peripheral nodules, small incidental nodules. So this is the Fleischner Society guidelines, and this is a very famous set of guidelines. Have been written for many, many years. The most recent iteration of this for incidental pulmonary nodules is about 8 years ago, and this was a picture of Fleischner, and it's largely a radiology society, but there are some surgeons and pulmonologists. I think it's a lot like the skull and crossbones. You have to get tabbed in order to be a member of this secret society, but there are a few of us that secretly are in this society. So this society specifically is focused, we'll just focus on the subsolid nodules, and you can think of that as two different aspects. One is the transient one, so these things disappear and they are of zero consequence to all of us here. But then you have the persistent one, which really, the persistent ones really mandate the guidelines for how do you manage these persistent nodules. So this was these architects came up with this very, very simple, straightforward guideline policy that you could easily follow. You can look up there, it's very easy to follow. And if I was giving a talk just on subsolid incidental pulmonary nodules, that talk really could end here with this slide then by me, which is the end of the talk. But unfortunately, that is not quite the situation, because it turns out that the problem with the world is that intelligent people are full of doubts, while stupid ones are full of confidence. So if you look at this very simple schema, and you look at it hard, and I try to translate this into my current practice, I find a few funny things that I don't really do. Like the even less than 6 millimeter nodule, you have a patient that has that as an incidental, you are not getting away with just sending them out. You're going to follow that person with another scale. That's just the way it is. And this idea of even following something for 3 or 6 months and finding stability, that you're going to go to yearly, that's hard. That's a hard sell on a patient. And up top on the comments, in certain suspicious nodules, well, that definition of suspicion is different for probably everyone in this room. And the final thing down at the bottom, there's multiple less than 6 millimeter nodules. We're finding these multifocal cancers, and we're learning from Asia and some of the patients of Asian origin who we happen to see, where many of these guidelines really don't apply. And this is all confounded by this problem, which is this lead time bias. So how many of these things that are minimally part solid, minimally invasive, or ground glass are actually going to become a problem for the patient? So you have this huge lead time bias that you have to somehow work into this. So not only do you have these vagaries in guidelines, you have at some level a heterogeneous uptake of guidelines across various societies. So this is what I pulled out, and I was part of this guideline development, which was venothromboembolism in our thoracic surgery patients. And we thought, okay, it's pretty obvious. And we surveyed a lot of societies about, because every society has a guideline on this. And if you look at how homogeneous these guidelines are and how doggedly they are followed, you find this smattering of some societies are doing a lot more TEDs, some are doing low molecular weight heparin, some are doing unfractionated, some are doing nothing, some are doing DOACs. You just find this. And so where do these guidelines actually fit? Well, I think, again, that distills down to the rules of common sense. And it turns out the rules of common sense don't stop applying when you're treating early stage lung cancer. And that's why this group, headed by our fearless president, Dr. Howington, set out to write these guidelines, which have a fair bit of common sense into them. Again, they can't be really strict pronouncements, because we have to be careful about making them way too restrictive. But they have to have common sense, and they have to use data in order to generate these guidelines. So these are some of the questions that we had asked, and when you make guidelines, you always like to have a North Star direction. And some of these are pretty obvious. What is the comparative efficacy and safety of adjuvant therapies for early stage lung cancer? And we heard Dr. Kim talk about some of this in later stage, but this is all early stage. But you go down this list of questions, and then you've got to get all of the articles. And this is a heroic effort by a large team that includes a lead bioepidemiologist, biostatistician, Leslie Souter, who helped us with this, where you're looking at multiple records. People are reviewing these things. And ultimately, these were what we came up with. And this is just recently published. And I'll go over a few of these, and I'll get a few of them in a little bit more detail. So in patients with clinical stage 1 non-small cell lung cancer, we recommended minimally invasive approaches over thoracotomy. Now, most guidelines are based on some kind of collation of data that then points one direction or another. Well, this guideline actually presented new data, believe it or not, where a very large meta-analysis actually demonstrates, really for the first time, that minimally invasive approaches for early stage lung cancer are safer for patients. So this is actually new data. And so this came in as one of our major point of emphasis. In patients with clinical stage 2 non-small cell lung cancer, we thought that minimally invasive approaches or a thoracotomy were reasonable. That wasn't something we were going to die on the sword with. In medically fit patients with peripheral less or equal to 2 centimeter nodules with a ground glass or lipidic component as a significant component, we let the user decide which of those they were going to employ, whether it was a lobe, a sublobe, or a segment, or a wedge. Now, in practical use, if someone has a pure GGO and it's peripheral, I think most people who do these operations for a living would just do a simple wedge. There's ample data to suggest very low recurrence risk, very low lymph node risk. So the idea of limited lymph node sampling comes into play. So there's a lot of nuance just with a recommendation like this that we have to leave at the discretion of the end user. In the medically fit patient with a peripheral nodule, 2 centimeters or less, with solid or mostly solid components, so stage 1, which is an invasive cancer, we suggest lobectomy, segmentectomy, or sublobar, a non-anatomic wedge, as equivalent alternatives. And this is really new knowledge that has been informed, and we'll get into some of this, with recent randomized, fairly large studies. In medically fit patients with clinical stage 1 tumors that are either centrally located or greater than 2 centimeters, we recommend lobectomy. Again, this gets to a practical aspect. Could you even do a segment in a case like this? You probably couldn't. You're crossing segmental planes. Is it worthwhile to do a medial or lateral segment in a middle lobe for a lesion like this? The answer is probably no, in part because some of this stuff will be confounded by margin distance. And in the guidelines, we have actually specified that we expect at least a 1 tumor diameter distance to the margin, if not 2 centimeters. So again, these are general guidelines. End users have to really apply them appropriately. In medically fit patients with clinical stage 2 disease, we recommend lobectomy over sublobar resection. Now, this is a common sense recommendation by us, and so stage 2 would generally be a higher lymph node involved here. But there is emerging data, scant as it might be, where even segmentectomy with a positive lymph node, outcomes are not significantly different from a lobectomy in that patient with stage 2. So fast forward for Dr. Howington 10 years from now, that may change. But right now, best we can tell, this is a common sense edict here that a stage 2 cancer, I think really because of the ability to meticulously do a lymph node dissection and really stage the cancer a bit better with a lobe than a segment, I think is the way it is. You get much more higher lymph node information because you're taking more parenchyma. And I think you are a little bit more fastidious in the mediastinum as well. And then the last one of these guidelines I wanted to really just bring up, there's 17 of them in the manuscript. In patients with clinical stage 1 considered high risk for lobectomy, and high risk again, it's the eyes of the beholder, it's the depressed DLCO, it's the desaturation on a walk oximetry, it's some fibrotic lung disease that you notice on the CT scan. It's a variety of these things, and there is, I think, an AATS or STS guideline that defines high risk lung cancer surgery patients, but we recommend lesser operations. Again, this is punishment has to fit the crime here, and to punish a patient like that who has marginal pulmonary function with a lung deficit that you're creating from a lobectomy might outweigh the benefit of the impact on the cancer. So this is our schema that we came up with here, and this is again in the manuscript, and it's very straightforward, very easy to follow. There's a few things that I wanted to highlight, and that first was this, which was one of the first guidelines I showed you, which was this idea of minimally invasive operations being done for early stage cancers. That is here to stay, and with the data that's published in this guideline, it is now data-driven and data-supported. So minimally invasive operations, and these are why these types of operations are now metrics for quality on very large quality databases. So the one that we added, really, compared to what we had done in the past, was this peripheral 2 centimeter or less solid or invasive cancer, where we moved over from where we were before to include sublobar and segmentectomy as reasonable treatments if there was a reasonable presentation of the disease. And that's what goes down here. So we let the end user decide, but again, there is a fair bit of intellect that has to be imputed into this kind of equation. Now, this was different, and Dr. Howington and his band of merry writers some 12 years ago on the previous iteration of these guidelines had stood pretty fast on lobectomy as the gold standard for this presentation of disease. But this changed. So this is the stack plot and the meta-analysis of a variety of different studies, basically from 2010 to the early 2020s that were used in this guideline creation. I think there is one study from 2003 here. So none of these studies were used on the prior guidelines. So if you look there and you see, that the ultimate arbiter is that it's very close. You're close to neutrality here. But then you have these 3 studies randomized all within the last 2+ years, which really favor sublobar resection, and the Japanese study favors segmentectomy. So when you throw those in, it really balances out the pronouncement of sublobar resections being reasonable equivalents for lobectomy based on the location of the lesion and the ability to perform such operations. So not only is it overall survival, but when you throw all these studies in that looked at disease-free survival, you get some kind of neutrality. So you can pick and choose, but again, this is an end organ user. And just looking at the randomized trials for disease-free survival, they were also very neutral. Now, there are societies that have come up with far more granular descriptions of operations that should be done for certain presentations of early cancer. This is the JCOG heat map, where this group has done a tremendous amount of work on some of the specifics, and the x-axis up top is the invasiveness of the cancer from 0 on the far left, which is your lipidic or GGO, to the far right, which is a dense solid nodule. And on the y-axis is size, and you can mix and match what this group thinks about a certain size with a certain level of tumor to consolidation to tumor ratio, so invasiveness. And you can march it straight across, up and down, and there's some other trials that are still ongoing to inform this map. And that really gets to this idea, so you have to have some sense of your invasive component versus your overall GGO component. So a couple of things that are intentionally left off the guidelines that would serve to muddy the waters is that all of us recognize that there are certain early stage cancers that are good actors and certain ones that are bad actors. And to determine and distinguish the two is very, very difficult for us. And some people have tried. They've used PET scans. And this is the group that actually was involved with the CLGB study. This is the Weill Cornell group, or the Cornell Presbyterian group, that looked at PET scans and tried to come up with bad actors for early stage lung cancers where you may not want to do a wedge or a segment and default to the lobe. And it turns out that their final end of the day statement was that the SUV may not be clinically useful based on their studies because the patients who had these early cancers and had sublobar resections performed the same regardless of SUV. So if you looked at their data, and the far left is what they considered a low SUV, and on the far right was a dichotomized high SUV. Actually, this is the wrong data, but, oh no, this is correct. So you can look at that, no, actually this is the correct data. So if you look at this data, they said that the plot on the right was equivalent, but the curves are actually separating there. So there's some problem there with their pronouncement. If you looked at the JCOG group and what they looked at in terms of high SUV, low SUV, they took a group of high SUV, and when they asked the question, was there a difference in survival between segment and lobe, they actually found there was. So suddenly, that brings this whole idea of small lesions that are really, really active metabolically. Should they be treated with a lobectomy? Are you safe? Hard to tell. The last thing that you have to understand is about this lymph node sampling, and this is critically important for all early stage cancers in order to determine whether they in fact are early stage. Now this is our standard lymph node map, and our pronouncement on that last slide was that we have 3 mediastinal stations and at least 1 hilar. Now, 3 mediastinal stations, if you look at a right-sided lesion, right upper lobe, and you say, I'm going to take level 8, 9, and maybe 7, that fits along with maybe level 10, but I'm not sure that's the real spirit of the law here. I think there has to be some mental thought here that you're harvesting appropriate lymph nodes. For a right upper lobe lesion, I would suggest that you do the right paratracheal stripe, which is 2R, 4R, and subcarina, which are by far much greater chances of occult lymph node spread than a level 9 on a right upper lobe. I don't think I've seen that yet in my career. The contrary, on the left side, I think it behooves us to try to get down and get 4L. Now with some of our video and robotic techniques, I think you can harvest that lymph node. Historically, it was kind of left alone because of recurrent nerves and whatnot, but I think we got to take 5, 6, 7. We got to take 4, 5, 6, and 7 for a left upper lobe lesion. Now, some people have thought about doing these lesser biopsies, lesser lymph node dissections, and that's where this randomized trial came up, where they looked at a lymphadenectomy versus lymph node sampling. It turns out lymph node sampling for them was quite extensive, and they came up with identity between the two, which made me think that it seems like less is more here. Finally, I end with these two. The high-risk operative candidates, these are ones that we've talked about. We think lesser resections are reasonable there. And what Sam had just kind of reviewed on some of these cases that are locally advanced, we would consider for targeted therapy. I think you have to really default to that now. There's clear for EGFR and for ALK mutations. And then for those patients particularly with high PD-L1 expression, I think for stage 2, we're looking at chemoimmunotherapy. So these are the kind of questions. Most of these talks are done at surgical rounds that I give, so I'm used to dealing with a bunch of far less couth audience. So I always have to think about these questions that come back to me. Someone's looking cool. There's a few who try to attack the speaker, and it was already answered. And then there's some illogical random thoughts, and there's usually that much that actually is interesting. I end with this slide here, and Sam ended with the names. This is my kid's way back when she used to row. And there's a lot of people that are involved in these kind of guidelines, people that are listed as authors in this, but there's a lot of people behind the scenes. And everyone is in a boat, and we're all trying to row the same direction here. Even if you're rowing the same direction and you're all in a boat, you could be going the wrong direction. It turns out that my girl's boat was going the wrong direction. The boy's boat is going to the right. So just being together and rowing together, there's something else that you really have to make sure that you have the North Star. And I will thank you.
Good morning, everybody. I'll pull my slides up. So thanks very much to Dr. Howington and the CHEST organization for allowing me to present today. I'm one of the thoracic surgeons at the Montefiore Medical Center, and I'm going to talk today about our AATS expert consensus guidelines. One of the things that you'll notice here is that this was actually a little bit older, so some of the data here is actually fairly outdated at this point. So this is from 2023. And so the areas that we chose to focus on here were optimal clinical and pathologic staging, neoadjuvant therapy and adjuvant therapy with recommendation statements made for each of these. So again, thinking through, the timeline that we had put these guidelines together in. So you can see from the red here that we put these together at the end of 21 to the beginning of 2022. And this is a time where there's significant changes happening within thoracic oncology. We have the ADORA trial published at the end of 2022. We have trials looking into immunotherapy in the adjuvant and in the adjuvant and the neoadjuvant setting, and we have studies like the LUNG-ART trial. So, we put this together during a period where there was really this, I don't know why the slides are advancing automatically, where there's really this practice-changing literature, and you can see these are published in the Lancet, the New England Journal, so clearly big things to consider as we were going through our working group here. So, we did use the Delphi method as has been discussed with the STS group, and so we chose our practice guidelines as they were given to us by the CPSC from the AATS. We put together some PICO-formatted questions and then had a librarian that did a literature review and pulled several hundred abstracts and papers. We had 2 committee members review each of the studies to see if they should include it within the document or not. And from these, then, we created recommendation statements. And from here, then, we put them and submitted them for voting using this modified Delphi process. In order for a recommendation to be approved, we had to achieve 75% consensus. And then once this document was, all the consensus statements were approved, they were endorsed by the CPSC and the AATS Board of Directors. So the Delphi method, again, just briefly, so we went through, this was obviously during the period of just after the pandemic, so all through Zoom where several members met. We had put together our recommendations after we each individually reviewed the literature, and then we put together a survey, which you'll see in the next slide, just a survey monkey that, based on a Likert scale, had all of the expert panel members, which I should mention included 14 thoracic surgeons and 2 medical oncologists, but we voted from strongly agree to strongly disagree. For a statement to be approved, you first had to have 80% of the panel voting on the statement, and then you needed 75% agreement. And then a couple of statements had second and third rounds of voting to achieve this after we modified some of the verbiage. And I think to reflect what Dr. Murthy has said, you're not going to make these very extreme statements, so a lot of them had to be tempered back a little bit. And the recommendations that we have are mostly along the strong and moderate categories based on the amount of data available. And so you can see from the survey here, pretty straightforward, where everybody goes through and votes on the statement, the class of recommendation, and the level of evidence based on the literature. So the first area that we looked at were recommendations for optimal diagnosis and staging. And the first one, this is very common to practice for most of us, nothing really groundbreaking here, but appropriate staging of patients with newly diagnosed lung cancers should include CT and PET. And in addition, brain imaging and invasive mediastinal staging should be performed where clinically indicated. This had a strong level of recommendation with randomized data to support, and everybody on the panel agreed strongly with this. And most of this really followed NCCN guidelines, which are based on strong criteria to begin with. Obviously, one of the updates in this space, and I'm fortunate to be joined by one of my interventional pulmonologists here, is with all of the advancements we've seen with robotic bronchoscopy, where we're really able to get, peripheral small lesions. So this is, again, I think, a little bit of a changing space. The next area that we looked into, just mentioned by Dr. Murthy, was looking at the optimal extent of lymph node dissection. The Z30 trial was put together, which was one of the main randomized trials in this space, which looked at systematic sampling versus dissection and didn't find a mortality or survival benefit in that patient population. Several other lesser powered studies have also been done, and the results don't conclusively show should we sample, should we dissect, should we do a lobe specific dissection. So our group came to the consensus of what we see from standard 5.8 from the Commission on Cancer, that we should do the 3+1, at minimum of 3 mediastinal stations and 1 Hyler station, and everybody in the group strongly agreed with this statement. Next, we looked at the extent of resection, and again, this is a time where it was 2022, so the sublobar trials were really just starting to come out. So the statement that we made was really predicated on the 1995 lung cancer study group trial. And we noted that lobectomy remains the standard of care resection strategy for operable patients. However, anatomic sublobar resection may be acceptable for tumors determined to be low risk for nodal involvement based on size or radiographic/histopathologic features, and it may also be an acceptable approach for patients who are high risk for lobectomy. Clearly this is an area that's changing, or has changed drastically in the last few years, with now 2 strong randomized trials that show that for selected patients that, kind of easy to think about, peripheral, less than 2 centimeters, and likely part solid, we can get away with a sublobar resection. Japanese study supporting segmentectomy, whereas the CLGB Alliance trial showing that wedge and segmentectomy are likely adequate in this patient population. The last recommendation in this section was looking at molecular sequencing, and we note that early initiation of molecular sequencing and other biomarker analyses is recommended to select optimal preoperative and postoperative treatment regimens in patients with locally advanced disease. And as we get to the next 2 sessions, I think this becomes pretty clear. So, the takeaways here are that PET scans do play a key role in the assessment of nodal disease and distant metastases, and getting them before a biopsy, I think, is important so you know where you're going to target your biopsies to. Multiple factors associated with the risk of upstaging may influence the decision regarding mediastinal staging and when that's pursued. I think we have strong data now that we can do this with EBUS rather than mediastinoscopy for most patients. We definitely need molecular testing and PD-L1 staining early in the planning of multidisciplinary therapies, thinking of the changes in immunotherapy and targeted therapies. When we wrote this, lobectomy was the standard of care and the preferred treatment, but we now have high-level data that supports segmentectomy in selected patients, and we support, in this document at least, the 3+1 nodal evaluation system. So the next section is probably the more interesting parts of this, where we looked at neoadjuvant therapy and recommendations for locally advanced disease. The first area we looked at was radiation therapy, and we found that for medically operable patients with oncologically resectable stage 3 non-small cell lung cancer with N2 disease for whom surgery is planned, preoperative systemic therapy without radiation is recommended. And alternatively, for those patients with Pancoast tumors and no evidence of N2 disease, neoadjuvant concurrent chemoradiation is preferred prior to surgery. And here the level of data isn't as strong. The class of recommendation is more moderate. But if we look at other trials like the SAC trial where we tried to add radiation to a neoadjuvant chemotherapy approach, we don't find a survival benefit. When we look for Pancoast tumors, we have the SWOG trial. And again, these are older trials that look at neoadjuvant chemoradiation. When we think about what we should give for systemic therapies, so we thought that platinum-based chemotherapy doublet in combination with immunotherapy is the preferred neoadjuvant regimen for medically operable patients with resectable stage 2 and 3 disease that lack EGFR and ALK alterations regardless of PD-L1 status. And this was, I would say, when I bring in the next slide, which Dr. Kim had already shown us, we put this document together as we kind of knew that Checkmate 816 was coming out. John Spicer was one of the co-authors on this ECD, and so we would try to get bits and pieces of information from him. Looking at high PCR rates of 24%, which have been replicated in other studies, and not just an event-free survival benefit, but now an overall survival benefit. Strong support for neoadjuvant immunotherapy in addition to giving chemotherapy. And for us, as for the surgeons in the room, we also had surgical data to show that we can do more minimally invasive surgery, lower rates of conversions, less pneumonectomies. So these weren't going to be necessarily more challenging operations. And when we think about other trials since then, we now have a bevy of neoadjuvant and really perioperative trials that show that we can operate on multi-station N2 disease, and we can get patients through with survival benefits that extend to 5 years. Dr. Kim had mentioned a little bit about, looking at resectability. And, at this point, we still thought when we wrote this that we defined this up front. But, I found it interesting. If you look at this article from the 1960s, the author here notes that, establishing criteria for resectability is difficult, and that's because of the rapid progress in thoracic surgery. And, I think we're, again, entering one of these eras, thinking about at ESMO. We have the LungMate trial that was just published or presented a couple of days ago that show that out of 100 unresectable patients, 57 were actually resectable after getting a PD-L1 antibody. And, looking at a patient of mine that I took care of, we see a supercentral tumor up at the top picture that it's not going to be resectable initially, but when he had his neoadjuvant chemo and immunotherapy, all of a sudden he was resectable, and even though during pneumonectomy, did well, had a complete pathologic response, and it's great to tell these patients that based on Checkmate data, he's got a 95% 5-year survival benefit. The last statement that we looked at here was that for patients with resectable and medically operable stage 2 and 3 disease without EGFR or ALK alterations, neoadjuvant platinum-based chemotherapy with immunotherapy is preferred over adjuvant therapy. And here you can see this is expert opinion data, not from high-level data, and this was a more moderate recommendation. And one of the reasons that we had put this, we looked at this was when we think about adjuvant therapy, sure, people can say patients don't have to wait longer, maybe less of a chance of progressing, and we don't have to deal with the changes that neoadjuvant therapy induces. But, our group thought that when we look at rates of adjuvant uptake, even in a clinical trial setting, they're pretty low. Dr. Kim had presented this. When you look at Checkmate 816, more than 90% of those patients completed all of their immunotherapy. In the Empower trial, only 70% completed a full year of adjuvant immunotherapy. And we also have surgical data showing that there might even be better surgical outcomes. So our takeaway here is that surgery has a clear role for selected patients with clinical N2 disease, and surgically resectable patients to be treated with neoadjuvant chemo and now immunotherapy without radiation. Radiation should be reserved for Pancoast tumors. We have Checkmate 816 and many other studies now that support platinum-based doublet chemotherapy plus immunotherapy as the preferred standard of care for clinical stage 2 and 3 patients. And our group had the consensus that neoadjuvant therapy was preferred for adjuvant therapy. And then lastly, we focused on adjuvant therapy. And here we note that first, all patients with stage 1B to 3 cancers based on the 8th edition should be referred to medical oncology for at least a discussion of adjuvant systemic therapies. And we know that referral from the surgeon to oncology itself is associated with greater rates of uptake, which is needed. But this space is also changing, and now we know that for resected patients without pathologic nodal disease, there are even some high-risk features that we might want to consider. So it's not just stage, but things like lymphovascular invasion, VPI, and when we think about even another recent trial that was presented to show that this is changing, we have the AIM-HIGH trial published just a few months ago, where in stage 1 and 2 patients, if they're identified as having a higher risk of recurrence based on a 14-gene assay, giving chemotherapy, not chemo and immunotherapy, but just chemo, had a survival benefit. Next, we looked at molecular diagnosis and staining again, and here we state that all patients with resected adenocarcinomas should have comprehensive testing for molecular alterations as well as PD-L1 staining, and for squamous cancers, patients should have PD-L1 staining. This would ideally have been done in the preoperative setting before going to the operating room, but especially important if they haven't had it previously, and there could potentially be a role for rebiopsying as well, noting that there is some potential for sampling error based on a small bronchoscopic biopsy versus a resected specimen. We also applied this to the EGFR space and noted that all patients with resected 1B to 3A adenocarcinomas with an EGFR mutations should be referred to medical oncology for a discussion of adjuvant osimertinib. This was, again, at the time where ADAURA had come out. We see, again, a huge widening between these survival curves when you give adjuvant osimertinib to patients with or without chemotherapy. And looking at later presentation of the ALINA trial from just last year, again, survival benefit in the adjuvant setting for another targeted therapy. Immunotherapy in the adjuvant setting has also been of significant interest, and we, in this document, noted that all patients with resected 2 to 3A non-small cell lung cancer with PD-L1 staining greater than 1% should be referred to medical oncology for consideration of adjuvant therapy. This was, again, around the time of the Empower 010 trial, where we see a survival benefit in the intent to treat population, and this was really powered by the patients with higher PD-L1 expression levels. When we saw the Keynote 091 of the PEARLS trial, this turned things on its head a little bit. There's a survival benefit in the overall population, but when we stratify it by the PD-L1 high population group, the curves, they cross here, and there isn't that same survival benefit. So, not as clear-cut of an indication as we saw for neoadjuvant. The last statement that we made, which was also commented on, was postoperative radiation therapy, and we thought that port to the mediastinum should not be routinely given to resected non-small cell lung cancer patients with the kind of surprise pathologic N2 disease, and this is really predicated on the LungArt trial that did not find a survival difference when you had postoperative radiation versus not. So our takeaway here is that there is a critical role for reflex molecular testing and referral of all stage 1B to 3 resected patients to oncology. In the absence of positive lymph nodes, patients should be assessed for other high-risk features, which would prompt referral and consideration for adjuvant therapy. Trial from the ADORA shows that there's a significant survival benefit for EGFR-mutated cancers that are stage 1B and above. For stage 2 and 3A patients that have PD-L1 expression, there is data to suggest that adjuvant immunotherapy is associated with the survival benefit. And lastly, adjuvant mediastinal radiation for pathologic N2 persistent disease following an R0 resection is not routinely recommended. So overall, appropriate staging and multidisciplinary care are certainly critical in this space. There's a lot of nuanced patient-specific decision-making that's required, and we're certainly going further and further into personalized delivery of multidisciplinary care here. Multiple neoadjuvant and adjuvant options exist for patients with stage 1B, 2, and 3 non-small cell lung cancer. Molecular testing, looking for EGFR, ALK, staining for PD-L1 and other drivers is mandatory and really should be done early. And for patients eligible for immunotherapy, a neoadjuvant approach may be favorable. And when we put this together for the surgical audience in particular, we wanted to call out to our team that surgeons must be a part of the multidisciplinary team in addition to the other standard providers as well. There's definitely an update needed, as this was a 2023 document. There's several high-impact journals and publications that have been put together. So we look forward to continuing to work on this. Several people were involved with this, including Dr. Murthy, who was on the CPSC for this group. So there's certainly to thank, and I appreciate the time. Thank you again.
I just will make one comment because Sid alluded to it. When you're thinking about a segmentectomy in the JCOG trial, they didn't allow inclusion of patients with middle lobe tumors or composite basilar segmentectomy. So when you look at these trials, you got to read it into the fine print because, as Sid said, if you've got a tumor in the right middle lobe, the idea that you're going to benefit the patient by doing a segmentectomy is not backed by data. And then same thing with the basilar segment. If you take the entire basilar segment and leave them the soup seg, you really haven't given them a lot of physiologic benefit. So thank you all.